Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Kimani Hendricks, Multimedia Communications Coordinator for the foundation, and today Dr. Adam Chaifetz is joining us to talk about navigating medical care. We will obviously address questions and comments after the presentation, but before we do that, I just wanted to let you guys know that if you have any questions, please type them into the Q&A instead of using the raise hand feature. We're having some technical difficulties wherein Dr. Chaifetz cannot hear
I can see
us
you well now.
speaking, so we can't tell him what your questions are, and he wouldn't be able to hear you if you raised your hand and spoke directly to him. So he's going to have to read all of your questions out through the Q&A, and then he'll answer them that way. So Dr. Chaifetz is a board certified chiropractic neurologist since 2008. He has been the program coordinator for the Comprehensive MS Center in the Department of Neurology at the Jacksonville campus of the University of Florida. He manages programs through the interaction with patients, providers, and ancillary staff personnel. He's also a strong advocate for patients and interacts with governmental relations representatives and local and federal legislature. Dr. Chaifetz has been in clinical practice since 1987. His expertise has always been in collaborative medical environment. He has run and managed the largest chiropractic practices in Jacksonville, Florida. The first chiropractic rehabilitation center director in the city, Dr. Chaifetz has been at the epicenter of collaborative care with his patients, utilizing medical physicians in practice. His patients have always benefited from a thorough, I'm sorry, they've always benefited from a thorough comprehensive approach to healthcare. Forgive my tongue, it is tied up clearly. Dr. Chaifetz, I'll turn it over to you and you can start.
Okay. Can you hear me okay now? Okay, perfect. I want to thank the Multiple Sclerosis Foundation for the opportunity to do this. And thank you for that very warm introduction. So my presentation today is going to be our perspective here from the way that we run our MS Center in the neurology department. We want to go ahead and give you kind of an eye behind the scenes to show you some instances that we are experiencing now that we have the new year, and it's one of those things where now we are at a situation to where it's vitally important for patients to be aware of some things that we're starting to see, and I'm sure as patients you've started to see them too. So the first thing I wanted to start off with is kind of giving you a perspective of healthcare and how it relates to other businesses that are service businesses in our country, in the United States. So when you think of a service business, as a consumer of a service, and in healthcare we call them patients, but we learn in life through experience that sometimes the services that we use, we don't actually have a heck of a lot of control over the processes that occur within that service. So some of the examples that I can give you, that when you go to this service, you're almost completely in their hands. And what they tell you, you have to follow, and you don't have a lot of say so because they're the experts in the field that you go to them for. But when a patient in healthcare loses the ability to control some things, it can create some really, really anxious, angry, frustrating kinds of feelings that patients get, because there are a lot of processes that are behind the scenes that happen in healthcare that don't happen in other businesses. So as patients, and I know because I am a patient, I have prostate cancer and I am dependent upon specialists within that field, the best there is, to give me the best health care that I can get. And so like an MS patient, my expectations are very, very high for healthcare. And so as a patient, I'm in the same boat as you all because it makes patients somewhat anxious when they're completely dependent upon the provider within the system. So let me give you another example here of a service and tell me what your feelings about this is. Imagine if you want to go a restaurant, okay? But today's January 23rd, but the restaurant you want to go to doesn't have an opening until August the 12th at 3 o'clock. And so when you go, you want steak, but they say, no, we think pork is actually going to work better for you. And consequently, there are no prices on the menu. So this institution says if you miss your reservation, you can't come back for 6 months because we're booked. And if you miss three reservations, you're not invited back. So this is a perfect example of sort of like what healthcare is like when you think about it. So we endorse services like healthcare, or getting your transmission fixed in your car, or getting an estimate for a roof on your house. We endorse services where the demand for that service exceeds the supply for people who do it. And there are many reasons why the supply may be limited, and we'll talk about that. But when that happens, I mean, patients are going to feel pretty helpless about being caught up in a process to where they don't have a lot of control. And so everybody who's missed a doctor's appointment for whatever reason knows it's not an immediate thing to get in the next day, maybe not the next week, maybe not the next month. So for healthcare, the ramifications of things are a lot different than simply making a restaurant appointment, because we all know that we would not put up with that in the restaurant industry because there are so many to serve us. So I'll give you a little eye behind the scenes of how messages work in a neurology department. And we're an academic medical center. We're the University of Florida here in sunny but freezing Florida today. And as an academic medical center, we have resident doctors, we have attending doctors, we have medical students, we have a number of different people on our campus. But when you call our department, we have probably 15 to 20 providers. And so when a patient calls in, or when a pharmaceutical company calls in, or another doctor's office calls in, they're calling into a call center. They are not calling into your doctor sitting by the phone waiting for you. They're not calling into the doctor's nurse sitting on the phone waiting for you. Instead, what they're doing is they're calling into a call center, which really isn't even in our department. So if you go into a big rigmarole or you go into a huge history or something, you're not going to be talking to somebody who's a neurologist, a nurse, or even anybody who's even medically oriented. So these call centers are there to take messages from all types of calls that come into our department. That could be from patients, from pharmaceutical companies, from specialty pharmacies. Hey, we need a prescription. Hey, we need a prior auth. Hey, we need a, whatever. And so these entities will communicate with our department and our MS center. And all messages nowadays are routed through an electronic messaging system through an EMR, electronic medical record, and our specific record is called EPIC. Now, Epic is widely used among a lot of hospital systems. So what's really great about that is that if a patient transfers to us and we can see their medical records from a previous provider, it makes life a lot easier because we have access to their medical records without having to, request them. And so all messages that are called into our center, and these could be patient messages. I slipped and fell yesterday. My eye started hurting. I think I'm having a relapse. There's a whole number of things that we get and we encounter as staff that supports the MS Center. So even if the caller is calling in to speak to the provider, okay, we probably get hundreds of call messages. We probably get hundreds of faxes every day. And each secretary serves 3 providers. So it's one of those things where if a caller calls in and says, I have to speak with Dr. So-and-so about something, the likelihood of that happening is not going to be super high. And I'll tell you why. The message is usually forwarded to either a secretary or an assistant. Now, if it's a medical issue, it might be forwarded to a nurse practitioner or somebody that has medical expertise or acumen. Now, one thing that kind of amazes me, and I will definitely go over this with patients because we have received calls where patients have called in on an emergency basis. And I strongly suggest that you not do that in an outpatient setting because most of the time, MS centers, neurology departments, neurology offices are not set up for urgent or emergent care. And so we have literally had patients call in and leave a voice message when I wasn't available to answer that phone that they think they're having a stroke. Now, folks, honestly, this is something we don't mess around with because even when I relayed that message to the provider, he even said, you have to go to the ED. So if any time a patient feels they're having an emergent situation, obviously the best thing to do is to either go to the emergency room or go to an urgent care center, but have something medically done. Because let's think about it. If you're having a stroke and you have to drive to your doctor's office and it takes 30 minutes, that's not a perfect scenario. So we don't encourage emergency calls. Now, what some patients might think are emergencies are a different story. So patient symptom calls are usually read by a staff member and then routed to somebody else that's more qualified to handle the circumstance. So again, we're talking, providers may not be able to call every single person who leaves a message, but it doesn't mean that the issue is not being orchestrated behind the scenes. So this is an example of a call that was routed to me. And the reason it was routed to me was a couple of reasons. A provider was out of town. I'm very familiar with this patient. And it's an example, in my opinion, of how a competent staff member with experience in MS, how they can guide a patient through a situation which could very well have ended up in a hospitalization and in turn ended up being beneficial for the situation. So patient's on a very high level drug. And she called in very concerned. She didn't say it's an emergency. She called in and merely said, I wanted my provider to know that I've had 2 falls in the past 24 hours. And knowing this patient, I went ahead and gave her a call because probably one of the most important things about understanding a symptom or a problem is getting a proper history about it. So if you look at the top of my slide, you'll see the lady falling and you'll see the guy falling, but the guy's got the banana peel. So a history is very important to know why or how the patient fall. Did you slip and fall on water? Or were you just walking, had weakness in your leg, the legs went out from under you, and you fell. So what I did is I talked to her and I said, listen, it sounds to me like you may have a urinary tract infection, and I'd like you to go to your primary care doctor, ask them to do a urinalysis and examine what's going on. So she did that. Her PCP wrote her a prescription for an antibiotic. Her symptoms completely resolved. So that would have been a situation where this patient could have ended up in an emergency room, had MRIs done, had all this blood work done when she had a simple urinary tract infection. So there's an example of something, that may be handled that's not necessarily considered an emergency. Now, this is real important because we're getting a lot of patient calls on medication refills and things that are happening in the new year here. And for those of you that don't know, January in neurology and multiple sclerosis practices like tax time for accountants. It's the busiest time that our staff has to do reauthorizations, prior authorizations, whatever. And what makes this process sometimes almost impossible is when patients will change their insurance and not let us know, but call in asking us to do something about their medication being out. So if a person calls in and says, I'm completely out of medication, usually there's not a lot we can do to make that immediately go away. So we strive to figure out, okay, what is the reason the person's out of medication? And a lot of times, the reasons that patients are out of medication could be multifactorial, and I'll go into a few of these a little bit later. But the most important one is if you change insurance, folks, you have to let the office doing the authorizations know that. When a patient needs refills, you should give the office about a week because a lot of times these have to be reauthorized and the patient insurance has to be updated in our EMR system so that we can appropriately try to get some of the things that are needed approved for you. Now, call example number 2. All right, so a person calls in, and again, they're out of meds. And the reason they're out of meds is because they had a change in insurance. And so they get this ominous letter from the insurance company that says, we have given you a 30-day supply of your medication, and it is no longer, your drug is not on the formulary. Talk to your provider about changing it to something else. And so this is the point where patients start freaking out, okay? Because a lot of patients don't understand that when you change your insurance, there's no guarantee they're going to continue to cover your medication. The other thing is, when you go with the new insurance, you start from scratch with that insurance, which means they want to know everything that you've been on in the past. And it's a really tedious process every time a patient changes insurance. But let's say you're on a branded medication, one of those medications that has a name to it, and you get support from the company, and you don't know how you're getting your medication. Well, some patients are on patient assistance programs, and if that happens, these have to be renewed every year on an annual basis. So make sure you know to do that. Okay, and these applications are done every year. So if you haven't renewed your participation and you're out of medications, you most likely may be out of medications because that application hasn't been renewed. And some companies, it could be as easy as a phone call. All right, other companies have a bunch of paperwork that's required that makes the process even more difficult. So steps and patient assistance. So the biggest problem we're dealing with now are patients that were on Gilenya, patients that had coverage for years through either their insurance or the Novartis patient assistance program. Well, they have completely pulled the rug out, and Gilenya patients as of December 31st are no longer getting free medications from the Novartis patient assistance program. So we are getting messages now from patients who have been on Gilenya, which the generic name is fingolimod, and they're expecting our office to figure out for them a drug that they can get for free. And that is becoming extremely difficult now that all of the generics are out there. And I'll go into which drugs are generics for what. Okay, but let's say that you're on Gilenya and you want to transition to another drug in that same category. Okay, well, you can do that. And you go to that drug, and what has to happen is the office has to try to do a prior authorization for that drug, and most likely it'll be denied because it's not on the formulary. An appeal will have to be done, and if that appeal is denied, then the patient is offered copay assistance. But now what I'm seeing, even when we get to that point, we're starting to see these companies that are now referring patients for foundation funding. They're not automatically giving them free drug. And the reason that's happening is because now the Medicare rules have changed for 2025. And what that means to me is it seems like if the max out of pocket now for Medicare is $2,000, it seems to me that these companies now that are giving drug assistance are expecting the patients to pay that first $2,000 of that out of pocket. So it's gotten a lot more complicated. For those patients that have Medicare, you need to go to medicare.gov and look at what the Part D versus Medicare Advantage plans, what the difference is, what the responsibilities are, what the coverage is. All right, call in example number 3. I have paperwork that needs to be done ASAP. And so all practices should have a policy or process for dealing with forms. And the forms that we get, man, we get some that are thick. We get disability forms, FMLA form, patient drug assistance forms, driver's license forms for disability plaques. So staff members may be completing these for the provider. Many of these forms are really lengthy, okay? And honestly, I've done gazillions of these, and they take a lot of time and a lot of detail and thinking to do these. Now, most offices are going to charge a fee for doing these. Our fee here at UF, I think, is fairly reasonable. It's $15, but this does not include reports that a physician may have to do for like a law firm for either a personal injury case or disability case. And for most paperwork, we ask the patient to give us 7 business days in order to get these done. All right, the next call. So referrals, when we get patients that call in for referrals, usually it depends on where that referral's going. Like if we're talking about infusion therapy, approximately half or more of our patients are referred to external infusion centers from our facility. So those referrals have to be done the old-fashioned way through paper and fax. If we're referring to our own facility, then that's done completely through the EMR system called Epic, and that's done by the provider. So a patient might call in, I need a referral updated for physical therapy. It goes to the assistant sends it to the provider does it, it's taken care of. So that's sort of how the behind the scenes with referral works. Now, if a referred service, like let's say your doctor wants to get 3 MRIs of your brain, your cervical spine, your thoracic spine, but let's say they only approve 1. Okay, well, that may take some time for the person to get what has to be done approved, if they approve it at all, because we're starting to see insurances get really cruddy on the approval side. All right, so here we go again with my medication assistance has run out because the drug is now generic. So, here it is, January the 23rd. And we're getting calls from patients when they were notified last year by Novartis that their drug was no longer going to be covered. So we have patients calling in, I want a medication change with no copay. And so I think that world is going to diminish considerably in the near future. Because see, when you do a medication change, and I'll give you an example. One patient, because he was on Gilenya from Novartis, he wanted to go ahead and transition to Kesimpta because he called in to Novartis and he said, well, I just want to switch drugs to the other drug you have, because patients don't always understand what a drug change entails. So when you're on a drug like Gilenya, it lowers your lymphocyte count. Okay. When you go on a drug like Kesimpta, Ocrevus, or Briumvi, it depletes your lymphocyte count even more. So in other words, you can't just go on Gilenya one day and Kesimpta the next day. There's a period of time a person would have to wait for their lymphocyte count to come up to a safe level to start a drug that literally depletes your lymphocytes. So patients have to understand that there are many drugs now that are generic. And I know that the Multiple Sclerosis Society was just applauding all the generic formulations that were coming out, but it's really made it more challenging and more difficult for patients depending on the drug you're on. So here are your choices if you're a Gilenya patient. Okay, if you're a Gilenya patient, you got 2 weeks of drug left, you have to find a new way to get your drug. And so you can do choice 1, which is if you have Humana, United Healthcare, Blue Cross Blue Shield. I have a bunch of different formularies here. These are formulary lists for all the insurance companies that list what drugs are on their formulary. And so for those of you that have been on Gilenya, you can stay on it if you want. The cost of it is about $200 to $300 out of pocket with cost plus. And so it's not a hassle for people who can afford that. Okay. So if your insurance plan has a generic version of this drug, it's on the formulary. So when a patient wants to do a drug change, we have to give a reason to the insurance company to switch you from drug A to drug B. And we can't lie. Okay, if you've been doing great on Gilenya and now you can't afford it, unfortunately, that's the reason we have to put when we try to get your medication approved with the next drug. Okay, because if you're clinically doing well, we can't say otherwise, right? And so think about that. When we change medications and they read our notes and it says patient doing well and stable on Gilenya, well, that's a clinical reason, right? unaffordability is not a clinical reason, and insurance companies don't always respect that. So if you're on any of these branded medications, like Tecfidera, for instance, Tecfidera, Vumerity, if you're on either one of those drugs, chances are your insurance company is going to tell you dimethyl fumarate is your option. If you're on Gilenya, Zeposia, or Ponvory, chances are they're going to tell you generic fingolimod is going to be your option. If you're on branded Aubagio, they will have most likely teriflunomide as a generic option. And then lastly, for those of you who have been on Copaxone maybe forever and you're doing great, and now you're on Medicare, see, this is the tragedy of generics right here, is we have so many patients, approximately 40% of our practice at one time was on Copaxone. Okay, approximately 2010, you were either on an interferon or Copaxone, period. And so now it's gotten to the point where the generic version, if you had to pay out of pocket, it's $1,400. So most people can't afford that. So let's say you have a Medicare plan. Let's say you have a 10% copay. So your copay on the generic would be a minimum of $140 a month for that drug, if they even covered it. Okay, so a question to the audience, if somebody wants to answer in the Q&A or whatever, I'm good with this. Why do you think I put a Tesla Cybertruck at the bottom of this screen? Does anybody want to take a guess at that? No takers? Okay, so I'll go ahead and give you guys the answer to that. The reason I put that on there, if anybody knows how much these medications cost, a year's supply of Tecfidera, Gilenya, Aubagio, or Copaxone is equivalent to the cost of one of these Cybertrucks. So when patients are getting patient assistance on these drugs, that's what the material value of those drugs that commercially is worth. Okay. So another thing that we get to, and this is not an unreasonable request, by the way, this request actually for an MS center, I take pride in trying to do the best I can for patients that are leaving our practice because they're moving or their students moving on, whatever. But if you're ever moving and you need to transfer your care to another MS practice, it's not that simple to just walk into another MS provider's office. And we recently had kind of what I consider to be a pretty acute tragedy. We recently dropped United Healthcare participation here at UF. And that was very crucial for patients who were on infusion therapy, especially those infusion patients that were on a 28-day infusion schedule. So what we had to try to do is get these patients to other practices. But if you're moving to another city, the best thing to do is to query the MS Foundation, query the MS Society, query your neurologist to see if they know, hey, I'm moving to Cincinnati. Do you know a neurologist? And so there have been many times over my past 17 years where I've been successfully able to call or go online, find a practice, print their referral form, send a limited amount of records, send their MRI findings, send everything that's essential to get that patient set up so that in 3 months when they move to Washington, D.C., they'll be set up with a practice that can continue their treatment. So the patients who move, or the patients who are their network has been dropped from their facility, the infusion patients are the ones who are at the most critical risk. All right. And so another caveat about infusion therapy I'm starting to see is that patient calls in and says, listen, I got this letter from my insurance company. And again, United Healthcare comes to mind, that their infusion drug is no longer on the formulary of the plan. Well, what they're doing is they're playing games here. Okay, because like for instance, Ocrevus, Briumvi, Tysabri, these are very high level therapies. So what they're making the office do is a whole bunch of extra work to make sure that you can verify that this drug is medically necessary for you. So they're taking it off the plan to make it harder. Okay. So the practice has to ask for a formulary exception for the drug. They probably have to write a letter of medical necessity telling whoever this insurance company is that you've been on this. And then another thing that's really going crazy in the infusion world is infusions are mandating both authorizations for the drug portion as well as the administration portion, which is just a whole bunch of work for the offices. So some additional considerations I want you all to think about going forward in this year is that it is so important for patients, their caregivers, their families to understand every year what's happening in their insurance plans. And the first thing you want to do is you want to check the formulary. So for instance, I'll read to you the Humana Medicare formulary here. Okay, what drugs are on the formulary? Dimethyl fumarate, generic, fingolimod, generic, teriflunomide, generic, beta-seron, Copaxone, glatiramer, generic, Kesimpta pen, and Vumerity. So if your drug is anything other than that, this is what's not covered. Aubagio, Avonex, Vifirtem, Extavia, Gilenya, Mavenclad, Mazin, Plegridy, Ponvory, Rebif, Tecfidera, Zeposia. So this is why it's so important to check formulary lists. Here I have United Healthcare. Okay, United Healthcare has all generics, generic Ampera, generic Tecfidera, generic Gilenya, generic Copaxone. The only interferon that's on there is Rebif. So let's say you're on Avonex. Let's say you've been on Avonex since 1996. Okay, well, what do? The office has to do a formulary exception. I'll give it a 7 out of 10 chance, depending on the insurance company, that you'll actually get it without a fight. Okay, so it's important to understand that all these branded medications, you know, the ones that have dinners and all that good stuff, they're the ones that are going to be excluded from the insurance plans. So if you're on any of these drugs, Gilenya, Zeposia, Ponvory, they want to give you fingolimod. If you're on Vumerity or Tecfidera, they want dimethyl. If you're on Aubagio, you get teriflunomide. And then the newest that's going to be coming to the mix is going to be for Tysabri, which is Tyruko, the biosimilar. So infusion therapy also, I'll just mention, if patients are being infused in a hospital-based infusion center, then what you're going to see is that for cost purposes, they're going to try to move the infusion either to a home infusion or to an infusion center that doesn't have a hospital attached to it. Now, one of the things I wanted to warn people about are the Medicare Advantage plans. And these are really slick because if you notice that they have ads on morning, noon, and night. And if you notice, the Humana ones have green in the background. So if you notice, green is a big color with Humana because they make, I think, tons of it. And so when it comes to Medicare and Medicare Advantage plans, I want you all to think about the fact that, does it really make sense that they're going to offer you all these extra benefits like money back, medical, dental, and vision for nothing or less than the standard Medicare? Well, the patients who have gotten these plans, I think, are finding out that maybe not everything that they need or want is going to be covered the way they hope. So a little funny line there. If you believe that insurance companies are really in your best interest, then I can tell you where Santa and the Easter Bunny live. But seriously, these plans do have some serious restrictions. And the thing that I think many patients have to be aware of is if you're in the Medicare age, like myself, or you're a patient who was awarded Medicare because of a disability, you have to be very careful in choosing these plans. And I'll tell you why, because it may be difficult to go back to a standard Medicare if you ever had to do that. Go to Medicare.gov and look at the differences between these. So the problem with healthcare is very simple. In clinical practice, as clinicians, as an MS center, we don't strive to put the patient on the cheapest drug possible for United Healthcare. What we do is we're experts at what we do. We look at how aggressive the person's disease is, and we feel that we're going to manage them with the highest level treatment available. That doesn't always coincide with the insurance companies. Their goal is to deliver the minimum standard of care at the cheapest amount possible. So what we have is a business model that doesn't coincide with the model that your providers want, which is your best interest in their health care. And so what happens is, how does an insurance company really wreck healthcare? Simply by creating these webs of processes and forms and faxes and denials. And if you think it causes grief for you, imagine the grief it causes for the offices that try to deal with these people. But on the other hand, I want you to grasp something else, okay? Approximately 3 years ago, a drug that costs $120,000, you can now buy for $120 a year. Okay, so that's only a 10,000 time markup. So process that for a minute. Here, I'll sell you a gallon of milk for $5, or I'll sell you a gallon of milk for $5,000. Which would you like? All right. So isn't that a great deal? The healthcare system's broken because we're led to believe insurance is going to take care of all our healthcare needs. And so going back to what I started with, healthcare is a process to where patients can lose control over them, right? We go to our providers, we go to MS doctors, we go to MS nurse practitioners, we go to specialists, we listen to what they tell us, we respect their diagnosis. And then the insurance companies are the ones who wreck everything because they want you treated with what they want. Their pharmacy benefit managers make money off of denying drugs. And then the pharmacies that they own make money off of supplying your drugs. So we have a whole web of things that really complicates the entire landscape of healthcare. So think about this. We get a list of formulary drugs, and that's what they want us to prescribe. And not only that, but they want us to hop around and change drugs every year. If the formulary changes, we want you changed to this. It's really nonsense what they put providers and patients through. It's almost unbelievable, really. So just to let you grasp some numbers, in the late 90s and early 2000s, houses cost, a really nice house cost about $100,000. In 2008, when I started, the average disease modifying therapy, which was Copaxone, Betaseron, Avonex, Rebif, they were 3,000 a month. We were freaking out. 3 grand a month. Oh my God, 336 grand a year for MS meds. Now they're over 10,000 a month. So any of those branded drugs, if you go and do a search on what a branded MS oral drug is, they're all around at or around 10,000. And if they've come down, it's because they had to. All right. And with these statistics in mind, it's really hard to predict what's going to happen with healthcare because, I mean, the insurance companies have taken the power away from your doctors to really get you what you need without hassles. And I can tell you this with recent things that have happened in politics, that if they're going to be doing things like giving tax breaks to the very wealthy in our country, you can be rest assured that they're going to cut benefits from Medicare and Medicaid. So some takeaways from this presentation are: be diligent and understand what your insurance coverage is for medications and services. Patients now, I hate to say it, they're going to have to start being a team member and being involved in getting assistance for their medications, because now my understanding is there is no automatic free drug anymore. They're referring patients to foundations, and patients are going to have to apply for funding. And it's that whole game of waiting to see if funding comes in. It may not be there. It's something I haven't seen for almost a decade. Make sure you renew your patient assistance forms, or you renew your coverage with the company if they do it orally by phone. Insurance changes, they bring process changes, which means that if you have a new insurance, give it to us and give us an opportunity to get things in line for you. Compliment your provider staff. Your staff, honestly, they're the thankless folks in the office, behind the scenes, that get things done for you. I'm not proud of it, but I've literally been on the phone screaming to some of these insurance companies for the stuff that they pull, because it's made me so angry. And I really try to advocate for patients because, as I mentioned in the beginning of this presentation, I'm a patient too. And I hope in my medical office there's somebody advocating for me. So understand this, your providers are super important. They're very important, but they're not the entire situation. Even Tom Brady needs a team. And so a competent practice not only has competent providers, but competent staff that assists the providers in getting things done. And that's what I have for today. And I'll be happy to take any questions if anybody has any.
Uh, Thank you so much. Well, I'm saying this like he can actually hear me, but I wish he could. Dr. Chaifetz, well, we don't see any questions currently in the Q&A,
Okay.
unfortunately. And there are no questions at all on Facebook either. But I did just want to thank you so much, everybody, for joining us. Dr. Chaifetz, again, I know you can't hear me, but
I
oh
can,
God, thank
yeah, I
God.
can hear you. I
Good.
can hear you pretty well now.
Thank the Lord. I don't know what happened.
I think it was honestly my connection, because it's been so spotty. It was like 29 degrees here this morning. So it's just really, we've had really weather that's not been the norm for here.
Yeah, I heard yesterday there was snow in Pensacola, so I'm
It
just,
actually snowed here. It snowed in the Georgia at less than 20 miles from here.
oh
So
my,
we've had plenty of people that couldn't even make it into work because they live on the outskirts.
phew. Wow, I'm glad that we were able to have this chat with you. I actually do see a question.
Okay, I'm ready
From
to hang out.
awesome. From Corey. They ask, may a patient carry their records to a doctor?
Yeah, I mean, you can absolutely. I mean, that's actually a great question. If a patient has gone to the point of having their own records, I give them a gold star. And what I would do is I would get a 3-ring notebook and carry it, you know. But yeah, that's awesome. I mean, an office will usually scan those and then give it back to the patient. So that's as a matter of fact, we would appreciate that if a person did that in our practice.
Yeah, it's actually unheard of. I haven't heard of that, but you should. I would if I were in.
It's rare though, because so little's done in paper these days. You literally have to request your records to be printed because everything's electronic. Um, and so it's one of those things where, like if a person wanted their medical record here at UF, they would have to go to medical records and they probably would put it on a disk for them or burn it to you know, one of these.
Yeah.
So and make it a file instead of that. So yeah, anything you can do to to make it easier for the office to know your past history, your MRI findings, drugs you've been on, all these things are a huge help to your future provider if you're changing providers. Okay, and then it says, I just want to thank so much for being real with us. I've experiences changing from Aubagio to teriflunomide. I've had MS for 27 years and I've seen and heard things. Okay, so um, for Suzanne, you know, you have an option of going to Cost Plus. If you register for Cost Plus, teriflunomide is very affordable. It's about $12 a month. So you're not going to find an MS drug that's going to be cheaper than that out of pocket. The next most affordable drug that you can get at Cost Plus is going to be dimethyl fumarate, what used to be Tecfidera. That's a very high level drug. 35 bucks a month is very affordable compared to the 10,000 a month they used to charge. So hopefully that's the good info for you. And then Anna says, yeah, I agree. A doctor can be great, but the office stays. Yeah, because guess what? Hate to tell you, but the providers don't do everything, Anna. Okay, little hint there. And I know you all know that. And just like I put on the Tom Brady wouldn't be great without his team, right? So thanks for the information on insurance and especially Medicare and the medication processes that can be complicated. Thank you, Leslie, for that wonderful compliment. Um, I always try to present information that you're not going to hear in another format. Your neurologists, your nurse practitioners, your physician's assistants, your physical therapists, they're your providers that have enough on their plate. This stuff is not only intricate to understand, it's really maddening. And between our clinical pharmacist and I, we literally have to go to therapy because of dealing with these insurance companies. And I'm being funny, but I'm saying that because they put us through hell. And they put us through hell because they want to make the process harder because they don't want to pay. And it's just one of those things where people have to understand that if you get these denial notices and things from your insurances, that more times than not, it isn't that the office isn't trying as hard as they can, you know. Question is, does MS burn out after a certain age? Can these meds be used in older adults? Well, Sandra, yeah. So what can happen is what we see is patients that have had MS for a long time, that have been on drugs for a long time, and maybe their disease has quieted to a point where, they're asking their neurologist if they want to stop a drug. There are even drugs now like Mavenclad that offers you the opportunity to dose for just 2 years and then you don't dose again. So there are some options that are available if you're thinking about curtailing a drug. But if your neurologist or your nurse practitioner or your MS specialist says, you need to stay on drug, I would respect that opinion. It's always wise to bring it up if it's a question for you. It's never wise to stop it and then tell your provider. Okay. And
Chaifetz, I'm sorry. There was a question someone put in the chat from Nancy. She says she has UHC. What should she do? And she's nervous.
it depends on what her circumstances, what med is she on? So if she's on a certain med, like let's say she's on a branded med, the office that she goes to is going to have to do a formulary exception if she's on Ocrevus. Most likely that's not going to be a problem because that goes into the medical portion of the insurance process. It's not part of the pharmacy part. So, Ms. Thomas, you should be okay. The office or the facility just needs to go through whatever they've been going through previously with your insurance. Now, I would also reach out to Ocrevus too and make sure that you have an understanding that there are any changes in their program if you get assistance from them. Okay?
Yes. It doesn't look like anybody else has
And it looks
questions.
like we just hit the hour, right?
It does. Yes. I'm so glad that we were able to
That's great.
clear stuff up and have some questions. And as always, Dr. Chaifetz, thank you for being the advocate that you are. I couldn't imagine the workload, but we thank you so much for what you do within
Oh,
MS
thank
Care,
you. The pleasure's
chiropractic.
all mine. The pleasure's all mine. And I forgot to say at the beginning that, I don't have any conflicts. I don't work for any pharma companies. So everything that you're hearing here is just straight from what we're actually experiencing. And I try not to be biased in any way, shape, or form, just to point out that there are certain circumstances that we're seeing repetitively. So I hope all of you the best of luck. And if anybody needs to get in touch with me, you can contact the MS Foundation, and they do have my contact information. Um, Let me see if I can put it.
Well, Dr. Chaifetz is putting his email in the chat. We just want to thank all of you guys for joining us today.
That's .org. I'm sorry, not. Oh, okay. There we go. All right.
No
So
problem.
thank you all.
Thank you so much, Dr. Chaifetz. Before everyone goes, I did want to let you know that we have another teleconference coming up next Tuesday, the 28th at 7 p.m. Eastern Time with Tiffany Malone, who will be talking about anxiety and MS and why mental health is just as important as our physical health. Again, Dr. Chaifetz, thank you so much. We appreciate everything that you're doing and have done and will do. Thank you for your transparency and your
Thank
honesty
you.
as well.
Thank you all, and have a great day. Good to see you all.
Good to see you. Bye, everybody.